Are we ready?
Yeah, I think we should start.
Yeah. Okay, great. Yeah. Good. Welcome, everyone, to our Thursday DMICE Research Conference. Kicking off, I guess we're kicking off the winter quarter. Today's presentation will be a Clinical Informatics Journal Club that is sometimes moved into this slot when the slot is otherwise open. Just before we start, I would encourage everyone to let us know if you want to present, or if you know of someone who you think might want to present, even from another institution. We're trying to do that. It's one kind of silver lining of the pandemic, as people don't have to travel all the way. We're trying to line up a few outside speakers. And then also, I just want to, as I always do lately, encourage people to take advantage of the offer to get the COVID-19 vaccine. And there's also going to be some opportunities for people to volunteer to take part in the big vaccine efforts as soon as more supplies arrive from the federal government. And you'll be hearing more about that. So anyways, today's speaker is Dr. Benjamin Collins, who most of you know. He's a first-year clinical informatics fellow in our program. He is a physician and trained in internal medicine at Temple University in Philadelphia. And also, during that time, earned a master's degree in urban bioethics. He has broad interests in EHR design, medical education, health technology ethics, and addressing health disparities. So he's going to present this article to us, and I'm sure there will be time for discussion when he's done presenting. So go ahead, Ben.
Good morning, everyone. Thank you for attending the Journal Club today, and thank you, Dr. Hirsch, for the introduction. I'll be presenting an article from JAMIA in 2020, Factors Associated with Nurse Well-Being in Relation to Electronic Health Record Use, a systematic review by Oliver Nguyen and others. So to start off with, what is burnout? Burnout is an increasingly recognized phenomenon in healthcare. This article used a definition from the AHRQ that identified burnout as a long-term stress reaction with emotional exhaustion, depersonalization, and a lack of sense of personal accomplishment. I believe this to be a very important topic for four main reasons. First, burnout is very common, including within nurses, with between 15 to 45% of nurses experiencing burnout at any given time. Second, burnout in nurses has major consequences, including decreased quality of care, increased healthcare costs, and increased system inefficiency. Third, there's a large disparity in the research on burnout in nurses as compared to physicians. Although there are many more nurses than physicians by a 4-to-1 ratio, there are a lot more studies of burnout in physicians than in nurses, also by a 4-to-1 ratio. And lastly, the EHR is well known to be a significant source of burnout for physicians, but the relationship between the EHR and burnout for nurses is much less established. So this article set to perform a systematic review on the existing literature with two objectives in mind. First, they intended to assess multifactorial and multi-level factors associated with EHR-related indicators of nurse well-being. And second, they intended to summarize potential EHR improvements recommended by frontline nurses in the articles. To do this, the authors browsed Medline and other academic databases for relevant articles using a set of key terms. They included articles in English from empirical studies with original findings that were performed in the United States and that examined EHR association with well-being or burnout in nurses. The reason they included only studies in the United States was to avoid confounding factors that may influence the relationship of EHR and burnout, such as documentation length, which is well known to be very different in other countries. For the included articles, they also adapted a risk of bias assessment tool to assess the quality of the study. From their initial search, they found 4,583 potential articles. From this, 26 articles met the criteria based on a review of the title and abstract. From these 26 articles, 12 met the criteria based on a full text review. The study quality of these 12 articles were then assessed using the risk of bias tool, and the authors determined that 4 articles had a high potential of bias, and these 4 articles were then excluded, leaving 8 articles in the final analysis. Of the other 8 articles, 4 had a low risk of bias, and 4 had a moderate risk of bias. Of the 8 articles used in the final analysis, there were 5 quantitative studies, 1 qualitative study, and 2 mixed method studies. The studies with quantitative components used observational or quasi-experimental designs. The studies with qualitative components used surveys or interviews. 2 of these studies examined only one specific type of nurse. One study evaluated burnout in RNs and 1 for NPs. The other studies did not specify, or they studied multiple types of nurses. Only 1 study evaluated nurses in the ambulatory setting, and ICU nurses were overrepresented by the included studies. In the main article, specific numbers of representation were not reported. I hope to be able to provide more specific details from the supplementary appendix, but unfortunately this was not available to access for me. From these 8 articles, the authors identified a number of influences on the relation of EHR and burnout. First, they did affirm that nurses using EHR were more likely to report burnout than those who worked with paper charts. There were conflicting findings on if age or overall experience of the nurses were related, but some studies did correlate older age with increased risk of EHR-associated burnout, and nurses with more experience having lower EHR-related well-being. The authors also found that LPNs had better EHR well-being compared to RNs. Other factors that were associated with better EHR well-being included personal comfort with computer use, caring for adult patients compared to pediatric patients, working on surgical floors compared with working in ICUs or on medical floors. There were a wide range of factors assessed that did not have an association with EHR-related burnout in this study. Notably, time spent in the EHR was not related, and I will discuss that more in a moment. Other factors include organizational factors such as practice type, number of clinicians in the practice, the use of scribes. Nurse factors that were not related included sex, education level, prior experience with EHRs, hours worked on a weekly basis, and shift type, whether day or night, perceived EHR mental demand, or perceived effort. EHR factors that were not related include the use of remote EHR, integrated interface displays. It is significant to note that 3 studies used Epic as their EHR platform, but the other 5 studies did not report the EHR platform used at their institution. The authors also listed several recommendations from nurses included in the studies. These recommendations for improving EHR include more EHR training, more access to computer workstations, improved EHR usability, improved attention to EHR workflows for nursing tasks, and increased nurse participation in EHR designs. The authors discussed in detail a number of their findings from the review. First, it was noted how factors for burnout differ for nurses and physicians. The factor that stood out most to the authors in this context was how time spent in the EHR was not associated with EHR-related burnout for nurses. For physicians, there are a number of studies that do link time spent in the EHR with burnout, as well as the use of remote access to the EHR outside of work hours. The authors concluded that this points to the importance of the amount of effort being more important to burnout in nurses than the time of effort. They admitted that due to the variety of roles that nurses have and the variety of work environments and expectations and the lack of specifying that in the studies, it is difficult to really discern the effect of EHR time or nurse well-being. The authors also state that in the discussion that interface displays may reduce cognitive load, leading to decreased burnout. Acknowledging also the recommendations to improve EHR interfaces and reduce cognitive load. To do so, they suggested including digital literacy in preparing nurses to enter the workforce, using integrated displays to consolidate information to help with decision making, and for this to be supported by organizational policies in healthcare systems. They especially point out digital literacy is a protective factor against EHR-related burnout and suggest there should be a greater focus on this along with EHR training in nursing school curricula. There were a few important limitations highlighted by the authors. First, the use of various methods and outcomes made it more difficult to derive meaning from the review. Because of the few relevant studies, they were also willing to use more indirect measures of burnout. And learning about the relationship of EHR and burnout for certain types of nurses could not be done well due to the lack of information on nurse types in some of the studies. They also reported a concern about limited generalizability in the setting that state and local laws and policies may have an influence on the findings. So in terms of my thoughts, the first thing that really stood out to me in this article is how it highlights the importance of nurse informaticists to guide EHR implementation and updates, avoid unintended consequences in EHR use for nurses, and to serve as advocates for the inclusion of nurses in informatics projects and research. As a physician, I need to be actively aware of the workflow of other roles, whether that is the nursing role or a pharmacy role or another role. There's also a clear importance for organizations to be committed to the role that technology plays in healthcare. If computers are necessary to perform work, then every individual who has a need for a computer should have direct access to one. I have been exposed to organizations where a lack of computers led to frustration of both nurses and physicians trying to use the ones that were available. And ultimately, students are the ones who end up with the short end of the stick, where students of every profession are often kicked off of computers and given very limited access when the ability to use computers are essential to the roles that they are supposed to be learning. One concern I had about the methods in this review was the process for excluding articles with a high risk of bias. It is not clear from reading the methods section if this was planned beforehand or if they decided to exclude those articles only after doing the risk of bias assessment. Another concern I had with the article, although it may be more related to a limitation of the articles that qualified for the review, is there was no acknowledgement that the second stated objective to summarize potential EHR improvements is not really met. The articles did not have much regarding recommendations, and the results section only contains 2 sentences directly addressing this objective. The authors do provide more recommendations in the discussion section, but these recommendations from the authors are inferred from some of the studies and not a summarization of what has been recommended by nurses. I would also note that the recommendations included are helpful to know, but from this article, it isn't clear if those recommendations would decrease the risk of burnout for nurses. I suspect that would be a potential outcome from those recommendations, but in the study there is no evidence to support that. I would also like to have had more commentary on why some of the findings may have been related with EHR burnout, instead of proposing the proposal of hypotheses that were sound but not necessarily supported by the review, such as the EHR interface reducing cognitive load. It is a premise that I agree with, but nothing in the review itself suggests that to be the case. Instead, addressing questions such as why do the authors think, for example, that nurses on surgical floors had less EHR-associated burnout than nurses in the ICU or medical floors, especially given some of the other findings that were unrelated to EHR burnout. In conclusion, it is apparent that more research is needed on the topic. There are many gaps in knowledge, and there are few quality studies on the subject. But from what is known, it is clear that informatics can help do more to support nurses and reduce the risk of burnout. That brings us to the end of my presentation. Thank you, and open for any questions, comments, thoughts, and also would like to hear the perspective of our guest, Dana Womack, if she's still present.
Hi, yes, I'm here, and thank you so much, Benjamin, for that great review of this systematic review. I thought that both your summary of findings and your observations were really astute, so thank you for that. As I read the article and listen to your summary, I also was struck with how difficult it is to study this issue, because the EHR is both a tool that you use to capture what you did. It also is a tool to help you plan what you need to do during that shift. And the issue of cognitive load, covers both planning, execution, and documentation of care. I just wanted to offer an example that might kind of help make this concrete, and also maybe give people on the call an idea of how we potentially study this in more robust ways in the future. There are things in the EHR that or there are certain tasks you need to do that are timed and they're repeated. So if a patient is receiving IV heparin, you need to, every time that heparin rate changes, you need to draw another blood draw within whatever the protocol is, usually about 5 hours later. And, you know, you would think that there would be like a nice way that every time you modify the IV rate that it would trigger for another lab to drop, but it doesn't. There's a PRN standing that the nurse needs to go in and time for like the next draw so that you can look at the lab at the right time and then readjust as needed. So let's just look at an example. Part of that is because the IV pump aren't integrated to the EHR in all settings. And that whole logic of, you know, okay, I did this, so now I need this timed effort, now drop this PRN order at this specific time, isn't automated. And so is that an issue of work design, of EHR design? It certainly goes well beyond any issues of user interface design, because it really, you could have a nice slick interface for your PRN meds, but that's not going to address the issue of making sure that that PRN is intentionally dropped at the right time to help you plan your work, if that makes sense. I welcome others' thoughts and comments along these lines as well.
Well, this is Bill. I will chime in. Nice presentation, Ben, and yeah, Dana, I definitely agree. I mean, the EHR is such a multifaceted thing. Another challenge to remember, and you know, we do have others in our department in DMICE who do a lot of systematic reviews, and actually some of us, myself included, have been involved in doing systematic reviews on informatics studies. One of the challenges is that the studies are not as homogeneous as we might ordinarily like when we're looking at a topic. So, you know, in this, we years ago, we did one on telemedicine, HIE. I don't know if Annette Totten is here. You know, there's studies that look at different things, use different methods, take place in different settings. So it can be hard to generalize. And so, you know, what you end up doing is, you know, what you've done here, you can kind of look across studies at some things, but to your point about, you know, not getting into some of the detail on what you might have liked to see across studies, it's just unfortunately difficult to do in systematic reviews. But still, you know, overall, this is a nice study, and you know, it does kind of paint a picture of what the research shows us in you know, factors relating to nurse burnout and dissatisfaction with EHRs, and you know, nurses oftentimes have less power in the hospital to do anything about it. So it's good to see this kind of research to you know, really point out the problems, and actually maybe organizations like AMIA and their very strong and well-organized nursing informatics working group can be a forceful advocate for making sure that nurses can deliver the best patient care with the EHRs that are foisted upon them.
Those are great thoughts. There is an effort, I think it's called 25 by 5, out of I believe, Columbia University, that they have a webinar coming up next month that's looking at reducing documentation burden for nurses that folks are interested in. It also is really just emphasizing Bill's point, like just the number of studies starting from over 4,000 in the area of nursing informatics in general, you know, filtering down to 8, just to see how this, you know, is an definitely understudied area.
There's a few comments in the chat box. Maybe Ben can take a look.
Yes, it looks like there's a number of some work in progress here that would be helpful to take a look at.
Yeah, you know, clearly we in the you know, informatics world, you know, people associate us with the EHRs that people are having to use. And so there's a lot of impetus for us as leaders and experts to make them better, although sometimes we too as informaticians come up against forces in healthcare organizations that we can't control. But it's good for people, it's good for us, if nothing else, to do this kind of research to point out the problems and come up with solutions on how to make things better.
So this is Vishnu. I had a question for Ben or Dana or anyone actually, which is, how much do you think organizations actually, what percentage of healthcare organizations do you think actually pay significant attention to nurse well-being? That's the first part of it. And the second part of it is, there are different kinds of clinical workforces, and one of the hallmarks of the nursing workforce is that it is, a unionized workforce with the ability to make, large-scale changes for its members and for the population of nurses. Has the nursing workforce in itself begun to understand some of the stressors that are existing in nurses today because of EHR use, for example, and are they taking any steps, do you know of, does anyone know of, to address those issues?
Here's what a few. They recently did an upgrade of the nursing documentation system, and it was designed to help better link documentation back to evidence-based practice and reduce the effort that's required for documentation. And they did the rollout was delayed due to COVID, but they did a survey before the rollout, and they're just now getting ready to do a post-survey. So I'm really proud of OHSU for looking at this issue a little more closely.
Yes, I think from my perspective, it would be helpful to have a better idea of the nursing workflows as an informaticist. Because my role as a physician, I'm primarily familiar with those workflows, but when I've seen nurses working, it is sometimes a convoluted workflow that doesn't necessarily make for a coherent day. And I think that it sounds like there is some movement on making some progress, at least here at OHSU. But I'm aware that it has plagued a lot of nurses in other organizations.
I think the attention sometimes goes up and down with, nursing shortage, and I'm anticipating, that with COVID and with, we don't know yet, but it's anticipated that perhaps people are going into healthcare with all the, recent concerns of the pandemic, and the difficulty of getting nurses, into training. As is with physicians as well, the difficulty of training people combined with potentially the risk of fewer nurses going into the profession, we could be facing a nursing shortage in the next, 5 years or so that could, in addition to the kind of growing momentum towards this topic, just really emphasize it, which would be a wonderful thing.
I see a a comment from Mike K on the surgical services typically having shorter clinical notes and length of notes, but unclear how that's related to the nursing burnout. And I think that is one of the things that when I was reading the paper that I did think about was that maybe there is a lower documentation burden for the surgical services, and that could be related to why there was less burnout. But again, without having a specific study on that, it's not very clear.
There's also a link between documentation burden for nursing and quality improvement efforts at hospitals. A lot of times for a quality improvement effort, you need one more data element, and we just need somebody to collect it. Well, who's at the bedside all the time? Who's well positioned to collect it? Is the nursing staff. And so often, an example is, like notification of critical labs. Well, you need to know, when was it known, and when was it communicated, and when was it acted upon? And so, hospitals have started putting in new forms just for nurses to collect all of that information where it's like something they're already dealing with and would normally do, but not document all of those little timestamps. But for quality improvement, it's needed. And so you think of, an organization puts out 10 quality improvement efforts, and each one of them has a little impact. It has a cumulative effect.
And when I was prepping for this journal club, one of the things I realized is how little we actually know about nursing burnout in general. If you look at the literature, there's this big chunk about physician burnout, provider burnout, which I assume, includes nurse practitioners. And then, there's this other kind of bigger kind of subset of clinician burnout. But if you look at a lot of those papers, they're actually talking about physician burnout, right? And so I don't, I would be very curious if, in your kind of, travels through the literature, you've actually come across any kind of quantifiable studies that look at the phenomenon of nursing burnout and what exactly, what is the epidemic that we're dealing with?
I have looked for good numbers. I wrote down Ben's 15 to 45 because, that's, I haven't had a hard number or really firm studies to point to. Sometimes it'll be like a study that's done specific to ICU or specific to whatever, and so you can't really generalize that to all of nursing. And so I haven't had a good solid number to refer to.
I think that's part of the issue, right? Unless we actually get our hands around to grasp the magnitude of the problem, how do you sell potential solutions? When you look at when you look at the problem of physician burnout, you can quote numbers, you can cite very specific studies that have been done that look at the magnitude of the problem, and so you're easily able to pivot towards a solution that makes sense from the workforce perspective, from the ROI perspective, clinical care perspective. For nurses, I really struggle to find that pivot. Even if we do make a case for EHR improvements to reduce nursing burden, how do we sell this to our organizations? How do we demonstrate the human resources ROI that will come out of a consequence of these interventions? I think that's part of the challenge of this process. We know the problem exists, but because we're not able to, we're still kind of wrapping our arms around the problem, we're not able to articulate what the problem is in order to identify what the solution is. That's my take on the whole kind of thing.
I think that's really insightful, and because there's so many different causes, and it's a multifaceted kind of thing, the solutions will probably be diverse as well. I also think that, there's room for rethinking how documentation is done as well, where in the future, you think of devices and documentation. It's already happening with vital signs and ID pump integration and bedside devices, but where the nurse is more validating data that's being answered by other devices And then you think of like the emergence of voice assistants where nurses can just do short annotations as they're working, and it kind of like builds a note throughout the day. That there could in the future, it could be a lot less of this, okay, I did my work, now I'm going to sit down to chart. Like moving that into real time and making it easy to do probably will take technologies other than the EHR or, integration that flows into the EHR in the future. I see the comments in there about protocolization, and I agree that if you have, like, if you're in a procedural area and you're doing something with a patient, it's like much more structured, and you can anticipate what's going to happen than on like a medical surgical floor where, patient's family have lots of questions and requests, and people develop nausea at unexpected times, and, just a whole variety. Can't find equipment, can't find supplies, need something urgently from pharmacy. There's a lot of interruptions that occur for things that are like really unexpected, and it would be very difficult to build a workflow around that is consistent.
Yeah, I think a lot of the discussion has pointed to, at least for me, things that weren't in this article at all in terms of how, like, for example, the idea of medical device integration. Some devices are in some cases already integrated into the EHR, and they're unclear if, like, some of these studies were in places where that's happened, and what effect that may have had on the results, along with different things like the use of medical equipment, the relationships of the work staff, and the one that did stand out to me was also the identification of the EHR, where 3 studies had used Epic, and then 5 studies didn't report which EHR was being used, and that makes it a lot more difficult to identify the relationship of the EHR with burnout.
And I see Christine added the link to that 2555 project, so I definitely recommend anybody who can register for those upcoming conferences that they have. There's also some, movement towards increasing informatics competencies in undergraduate nurses and incorporating it into curriculum. Like at OHSU, there's interest. A colleague over at University of Portland, Corey Pressman, who's actually an anthropologist, but very much into design, is helping them incorporate design thinking into their integrative health. It's a 300 level undergraduate course, and it's kind of exciting to see some innovation in education around this, so that you can help the next generation of nurses that are coming up be thinking about ways that they can affect the system alongside their basic nursing training.
And I was thinking about Mina's comment that, the nurse population is really heterogeneous, and that makes it challenging to generalize potential burnout-related findings and solutions. The physician population is also very heterogeneous, and we've managed to if you just do a literature search for, Christine Sinsky of the AMA, for example, just using one, example off the top of my head, she has been a vociferous voice for, advocating for solutions to burnout, which kind of spans through a multitude of diverse position workflows and roles. And so I don't know if the heterogeneity of nursing in itself is a barrier as much as the lack of resources that have been thrown at the problem. That is the real issue here. It's not the different roles that nurses play, but our inability to look at those roles and address and tailor solutions for them. I know Dana and I have had some conversations about how you can actually measure strain, looking at EHR data, right? How can you actually try and figure out the stress levels that nurses have, during EHR by looking at data rather than, surveys and asking them and doing the usual kind of front-facing things. And to me, that's not just limited to nurses. That's just so universal. If we can find a way to, in so-called real time, look at EHR data in order to identify people who are stressed in their jobs as clinicians, and we can target some resources to kind of alleviate some of that stress, whatever that may be. How important would that be from a patient safety perspective?
Mm-hmm. Yeah, there's a study that we're wrapping up right now. We have a set of data about nurses' perceptions about their shift, and then we went back and looked at more details of that shift, and then basically are looking at factors that differed across high and low perceptions of workload appropriateness. And some things stood out and are fairly obvious, like they didn't have overtime on the shift, they were able to take a meal break. Those are things that theoretically you could pick up dynamically in real time. Other things were like the number of medications that were dispensed before noon, and having a high percentage of the work intensity points come from medication popped out as a something that is a factor that gives or that is often present when nurses said their workload wasn't appropriate. Something that I have not had good access to data on that I think would be super interesting to study would be this idea of like cross coverage in nursing, where you have, heavy patients or patients with very limited mobility or traction, other things where like moving them, cleaning them up, after toileting, like requires 2, sometimes 3 or 4 people. We don't have any data about like how many of those patients are present on the unit and how much cross coverage is needing to occur. Cross coverage is also needed on meal breaks. And there's really, I did a search recently and I could find a couple of articles about cross coverage in relationship to workload and satisfaction among physicians, but absolutely none for nurses.
Yeah, so Mike says, I think in terms of ROI, it's still much cheaper to replace an RN as opposed to MD. So institutions will provide burnout prevention. And this is very true, unfortunately, but this is the reality of it. I also want to point out that, we have placed an emphasis on physician use of the EHR since pretty much the inception of EHRs. If you look at, even today, if you look at many commercial EHRs, the physician interface is a lot slicker, a lot more user-friendly than the nursing interface. And this is a tradition that we have kind of unwaveringly followed throughout the history of EHR, is to appease physicians as a group, much more than any other. And I think a lot of that has to do with what Mike said about the value, the cost value of physicians to a healthcare system. But whether it's, CPOE or CDS or any of those, big measures, EHR vendors and implementers have bent over backwards to accommodate physician workflows, while at the same time, you'll have this really, you have a good chance that you'll see this really slick physician interface in the EHR, and physicians will have multiple access points to the EHR, and the poor nurse has a screen that looks something like DOS, and it has one place in the ward where they can actually do all their paperwork. I think there has been a systematic push to maximize the utility value of EHRs to physicians compared to other groups. And I wonder, if as the literature for things like nursing burnout increases, that will spur a more kind of equitable way to look at how the EHR is being used across professions.
I like Mike's point, and would just add that from a healthcare organization perspective, a priority on reducing physician burnout and turnover, that leads over into what industry does, because industry is looking for things that their clients want. And I've had several roles in industry where my role was product concepting and coming up with ideas of how we can use technology to assist in the front line. And of course, given my orientation, a lot of my concepts had to deal with nursing. And it's interesting because, then you present it to the decision makers within a corporation, and they're like, oh, that's great. Do physicians need this? It's so funny. It's kind of a consistent response. There, to end on a positive note, I would like to just send, if you guys want to Google a positive note in nursing, is there's a group called SONSIEL, SONSIEL, I believe is how it's pronounced, and it's basically a group of innovators in nursing that have found each other. And they realize that, academia isn't quite the right home, practice isn't quite the home, they're kind of like floating out there. And so they've created an organization. They're planning their third hackathon, and it's a group to watch because I think they really can help elevate the voice and bring together nurses to focus on innovation and even start companies within the profession that can address these directly with firsthand knowledge of the challenges.
I just found their URL. It looks like an interesting site to visit. Any other? Yeah, go ahead.
One of the founders has a really great TED Talk. It's worth taking a look at.
And they also publish a book called The Rebel Nurse Handbook. So, good. Any other comments, questions? Okay, well, if not, we'll thank Ben for presenting and Dana for her insights and all the other discussion. And we'll look forward to seeing you all at the next conference.
Thank you.
Yeah, have a good day, everyone.